So many of you have been on our webinars before, so you can probably recite this yourself, but we are at the California Prevention Training Center, a multidisciplinary training and capacity building assistance center funded by CDC. And we are part of a national network of 8 different training centers. You can visit us on our website to get some of our resources, as well as, links to job aids, et cetera. And the National Network of Prevention Training Centers also has their own group of job aids, as well as some recordings of webinars, et cetera. And we also do a lot of consultation for difficult STI cases through the STD Clinical Consultation Network. So that's us. And as I mentioned, that's the website for the complex STD cases. A lot of what we get are syphilis, serology, and treatment questions, but really you can send us anything, and we are happy to help you. And again, we are staffed by 8 different centers throughout the country. So we cover as well Puerto Rico and the Virgin Islands. So if you're out there, please ask us a question. This is the boring stuff that I have to show you, but I refuse to read it because it's just legal speak. It's the compliance that we need to do to offer you CME today. And our CME provider is the University of Nevada, Reno School of Medicine. A note on disability, the American with Disabilities Act compliance or 508 compliance. So some of these may not fully meet accessibility requirements. And so if you need the content in an alternative format, please email captc@ucsf.edu and we will comply with that. Oh, sorry, I missed another compliance slide. Oh, and I think this is actually just a repeat. And I want to point out that this whole activity is linked to 1.5 AMA credits. And so most boards will also accept continuing medical education credits. And these are not CEUs, but they are CMEs. So in order to get your CMEs for free, you will have had to have registered for the webinar, which you did because that's why you're here. And you need to attend the webinar live and in full. And you need to also complete the post-course evaluation survey by March 13th. So that's about a week from now. But you are going to get the evaluation 24 hours after the webinar from an email that is training@nnptc.org. And many of you who've been here before know the drill. But if you haven't and you're new to us, please add us to your safe centers so that you don't get this evaluation getting sent to your junk. So in about a month, you will get your CME notification. There'll be a link there, and then you can download your certificate. And the CME notification is going to be sent from the email I mentioned earlier, which is captc@ucsf.edu. And add us to your safe and trusted centers so we don't go to your spam, please. Okay. And I think the thing that gives me the most anxiety as a webinar attendee is, am I going to get the slides? And the answer is yes, you will get all the slides approximately 2 weeks after the webinar. And so you're going to get a notification with the slide handouts. You do not have to ask. We will send them to you. And again, captc@ucsf.edu is who they are going from.
And if anybody wants to do any training on ASA cycles or the PATH framework, have questions, please reach out to me and I can give you whatever slides you might need, and some.
Yes, and Patty's email is going to be on the last slide of this webinar. Ooh. Okay, we're almost there through the housekeeping, Patty. The Q&A is going to be turned on for all of you attendees. And so this is not, unfortunately, a Zoom meeting where we have a chat function, although Patty and I would love that. We do have some polls for you to increase the interactivity, but you will be able to just put your questions into the Q&A. Dr. Kelly Johnson, who I think many of you know, is going to be monitoring the Q&A and then will ask us the questions at the end. And you will have until the last 2 minutes of the Q&A session to put in your questions. So unfortunately, you will not be able to talk to us. Your microphones will be muted and we won't be able to see you, but we know you're out there and we appreciate your support. And all questions funnel to the poor Elizabeth Olson, our program manager, who is at elizabeth.olson@ucsf.edu. But do not ask her if you're going to get the slides because I promise you, you're going to get the slides.
And any slides you want from me also.
Yes. And oh, by the way, right. You can get, if you need other slides, you can email me at the email address, which is going to be on the last slide, and I will send you slides from other topics as well. We like to share.
We like to share.
At the CAPTC. So now I'm going to read
I
about.
don't think we need to.
Well, can I read a shorter version of this, please?
You can tell them I'm a nurse practitioner who retired.
Patty is a nurse practitioner who has had over 40 years of experience in sexual reproductive health. And she was the lead author and editor for the huge textbook called Contraceptive Technology, which is sort of the Bible of contraception, I would say, and developed the PATH framework on person-centered communication using these cycles of affirm, share, and ask that we're going to demonstrate for you today, and has been on the board of many, many large national organizations, including the ASCCP, Planned Parenthood, and the Office of Population Affairs, and also helped out reviewing the CDC treatment guidelines. And she is currently the president of Envision and Sexual Reproductive Health, although she's kind of low-key retired now.
No, I'm not low-key retired. I'm retired. This is it.
This is it.
I know I said this last time, but now it really is.
Yeah, this is her last hurrah. She swears. And then I'm going to introduce myself, and I think some of you know me also. I'm Ina Park. I'm the principal investigator of the California Prevention Training Center, and I've had the privilege of being here since 2007. I've worked on the CDC STI treatment guidelines and worked on them in 2021 and also again in 2026. And I'm a professor at UCSF in the Department of Family and Community Medicine, as well as OBGYN. And I like to write books. I wrote a book on STDs.
I haven't read Strange Bedfellows. It's the best read. It's my favorite book I've read in years.
Thank you, Patty. So that's us. And hopefully you did not go to sleep because we're almost there. And I don't know why this is repeating. Now we are on our intro slide on shared decision-making and sexual health.
Yay.
And here we go. So here's our learning objectives. We are going to demonstrate shared decision-making conversations in at least 2 clinical scenarios. And in fact, we're going to try to get to 4 if we can do it. And we're going to describe common problems that occur and how to apply shared decision-making to help resolve them. And we're going to define what an affirm, share, and ask cycle is in patient communication.
And we're hoping you can do all those things too when we finish today.
Yes, exactly. I have no disclosures, and we do have some stock photos here from iStock. And Patty Kaysen is a consultant for Sabella Women's
Health that came out with the new IUD called Myudela.
There you go.
Which is not yet on the market.
Good to know. And so now our folks at CAPTC are going to set you up with a poll. And the question is, for those of you out there in your usual job duties, how often are you counseling clients or patients about decisions regarding their sexual health? So this is going to depend on how much patient care you do, if any. And so are you doing this type of counseling every day, 3 to 4 days a week, 1 to 2 days a week, or I don't see patients, I'm just here for the fun of learning from Ina and Patty.
And we could also do, I guess, 1 to 2 days per week or less.
Yeah, sure.
If it was less.
Yeah, a little bit less than half a day per week.
Half a day per week.
Yes. So please respond to the poll. Oh, they don't let me respond.
No,
only you can respond. I can't vote for myself, but please, you vote out there, and then we'll have them close the poll when they feel like.
Did you take that off?
I think,
you know,
they're going to show us the results of the poll.
Oh,
yes.
Interesting. Yeah, that is interesting.
Yeah.
Good.
So it's nice that we actually have some folks here who don't see patients and clients, but they just want to learn more about communication because honestly, you're going to be a patient someday. And this is a good thing for you to be aware of as well. But we have quite a few people who are doing this every day.
Yeah, that's really, a lot of you are really in there doing it. You're very active clinicians.
So you might be able to teach us some things, and please put some information in the Q&A if you have tips for us as well. So shared decision-making is literally everywhere. And this is just 4 examples that I found in the literature as well as living online from different large national organizations, including, by the way, the USPSTF says for every recommendation that is a grade level C or lower, that shared decision-making should be used for all of those. But I just want to point out that in particular, when it comes to lung cancer screening, you'll see I've highlighted the word shared decision making is important when clinicians and patients discuss screening. Contraception, I think, is, there's a lot of work being done by both you and Christine Dellendorf in this arena around shared decision making is the recommended approach according to ACOG, because patients both feel, a sense of empowerment as well as likelier adherence to certain methods, you know what I mean, if they feel like they're engaged in the decision. I think the most surprising thing, which shouldn't have been a surprise, is that the American Thoracic Society and the American College of Critical Care Medicine have a extremely extensive document around ICU care, because if you can imagine withdrawal of care, tube feeds, intubation,
all require a conversation.
All require a conversation. And the thing is that sometimes the patient cannot even make the decision and it has to be a surrogate. So they mentioned clinicians and patients and surrogates should use a shared decision-making process to define their goals, which makes sense, right, Patty?
Makes perfect sense. I want to add one thing about this that I think is fascinating, which is that they're recommending it for grade C and below. And frequently, shared decision-making is meant to come in when there is clinical equipoise.
Yeah.
Okay. So clinical equipoise, there's this option. I have breast cancer, I can get a mastectomy, or I can get a lumpectomy and radiation. And they both have similar outcomes. That's clinical equipoise. So when there's clinical equipoise, the decision is meant to be made by the patient with our assistance.
Right.
I'm going to argue shared decision-making is something that could be happening and should be, in my opinion, happening with things that aren't only a grade C and below. I think that no matter what the situation is, the patient's still going to be the one who's going to either take the medication or not, adhere to the treatment plan or not.
Right.
And really, the same conversation is important.
Yeah. And any of you out there who have been a patient will understand how important this is and how this often doesn't happen. And I just want to point out the last thing is chronic pain, which any of us who do clinical medicine realize is a very common condition. And they have multiple recommendations on how to manage chronic pain, including like chronic low back pain, which is very common. And again, those should all be based on shared decision-making with the patient. So everyone recommending shared decision-making. As I mentioned, the ICU care guidelines were very specific, and they said that in order to optimize this, that all clinicians should be trained in the specific communication skills they need. And I want you to remember this because we're going to come back to this in a second. Yes, just wait.
I just think that it's very important when we're talking about the difference between clinical equipoise and things where really there is a correct choice, right? There's one that is better for somebody's health than not. It's better to treat your gonorrhea than not treat your gonorrhea. So that's when there is not clinical equipoise. You still have the same robust conversation with ASA cycles that are going to allow the person who's learning, me, the patient, to get the patient education I need to make an informed choice. And that exact same process of conversation happens whether there's clinical equipoise or not, with one main difference, which is when there's not clinical equipoise, I absolutely step right into my professional identity and I say, I have a strong recommendation, or it is my recommendation that you do this. Early and often, recommendations are a very important part of shared decision-making.
Right. That's great. Okay, remember I said we're going to come back to that statement by the American College of Critical Care Medicine that clinicians should all be specifically trained in communication. So I just have an example here. So shared decision-making, motivational interviewing, or how to deliver difficult diagnoses or difficult conversations. When you were in training for your current role, how much specific training did you receive in any of these communication skills? And I'm going to personally disclose that I am under 10 hours for sure. But I'm curious for our audience out there.
Well, when I went to nursing school to be a nurse practitioner, we definitely had counseling skills as part of what we were doing. And I would definitely say it was more than 20 hours altogether.
That's fantastic.
Yeah.
We definitely had some those physicians in the audience. Many of you worked with standardized patients and perhaps had your interactions observed. And some of them, the time the patient would give you feedback about how they felt in your counseling. And some of the time it was actually around the content and whether or not you were presenting the right content and not necessarily how you were delivering the content.
Isn't that so true with standardized patients?
Yes. So let's close our poll and see. Aha.
Oh,
So about half of you have had not much. And I think that probably
that's,
tracks. But
yeah.
Patty predicted that there would be a group of you who've had extensive training in communication. So thanks for coming anyway.
Yeah.
And
And you're the stars. You're the superstars that I'm going to hope are going to contact me about getting slide decks to be able to train other people with.
yeah, and I think all of us can be better at communication
I
always.
certainly
Yeah,
can.
in our relationships also, not just in our job duties.
Oh, yeah.
So
So this is an
but
interesting concept, and it really stems a lot from contraception, and this is a lot of Christine Dellendorf's work. So if you think about it, consumerist counseling is when I, I, as the clinician, put out a menu of things that you can choose from, and then you tell me what you want.
mhm.
Not very interactive. I'm not really offering you much science here. I'm just giving you a menu, and it seems to me a waitress could do that, or a server could do that. Um, Directive counseling, that's what we're most, I think all of us who, certainly anybody who got out of school when I did 45 years ago, would have been doing this, directive counseling. This is the science. I know the science, so I'm going to tell you what to do. So it turns out that actually neither of these are great in terms of how patients are going to be experiencing the visit or their care in general. So that's why we come up with shared decision making as a way to be sort of pull the best of both. The patient's still going to get the menu, but they're not going to get the full menu. They'll only get the menu of the things that are appropriate for them. So if I give somebody a menu that's a complete menu in a restaurant, but they're a vegetarian, they can't actually eat a lot of the things on that menu. So it might be better if I gave them the vegetarian menu.
And yeah, and so it's not the dynamic of they're coming in and saying, okay, you're going to give me these 5 tests today. Do you know what I mean?
Exactly.
And it's not you saying you can
You
only
could,
have these 2 tests today. It's a little bit of a back and forth,
exactly,
hopefully an
exactly.
exchange so that everybody is happy.
And when
Oh,
we
go,
have,
go ahead.
you notice here that it says that you do motivational interviewing is utilized for shared decision making. Motivational interviewing, when it was developed and in its best form, is for behavior change. However, there's such great skills and techniques that are embedded in it. So as long as the goal in your mind and the patient's mind isn't actually about changing their behavior, but in fact just helping them to make a decision that's good for them, then I think we can use those skills.
Yeah. So Patty is going to launch a little bit into the affirm share ask cycles that we'll be demonstrating later. So I'm going to turn that over to you.
Do you want, am I going to?
No, I can drive. Okay. I can drive.
So there is a video series about this specifically. A lot of them are with sexual health examples, also reproductive health examples, and you can get them here, also through my website. And then there's another series.
Yes, and we just filmed actually this week with Dr. Johnson, who's off camera on this webinar, along with our partners at St. Louis Prevention Training Center and Southeast Prevention Training Center, another series of 3 to 10 minute videos demonstrating the ASA cycle with different sexual health topics. So we're going to have lots of resources for you, and you'll get this link on your slides, and you'll be hearing from us soon about this sort of course and toolkit with additional video resources.
So the first step in a cycle, as we're calling an ASA cycle, is affirm or acknowledge. So to say it's the first step, all that means is you've got information you want to share with the patient. The patient needs to know this information. But before you launch into it, do something to acknowledge them as a person. That can be if they've experienced or expressed some kind of an emotion, positive, negative, then demonstrate just a quick empathetic response to that. That's always sort of the top. If they've got an emotion, respond with empathy. No emotion, you could validate, you could find agreement, that's very powerful, or you could point out a strengths-based positive. So they've been using condoms consistently, whereas previously they had not. So you can, any way to acknowledge. These are just, the reason we break them down is just to make it easy for you to remember. So when you do provide a little bit of an empathetic response, it's really good to do that without labeling feelings. And you hear a lot in the counseling literature about labeling feelings. So I'm just going to, without getting into a long conversation about it, say I would strongly recommend you put that aside because your definition of anger and mine and yours are all different. So probably best to be generic, but to get that they are experiencing something emotional. It sounds like this is really concerning to you, or wow, that must be really hard to deal with, or just a wow.
That's a happy wow.
That's a happy wow.
Mhm.
I could do a sad wow, a happy wow, an
Mhm.
angry wow. Wow. Oh, I'm kidding. But we know not to say, I know how you feel, right? That's kind of a trigger.
Yeah. Okay, next slide.
So patients say things that we don't agree with. We don't agree based on what we know about the science. And sadly, it doesn't work just to say, sorry, you're wrong. So if you can find a core of something in what they're saying that you can agree with, like the fact that they went to the internet to find some information that was important information, and then build on that with a and. So whenever you find yourself about to say a no or that's wrong, try to think of a way to find something, yes, find something positive to connect on, and then use instead of but, and then add the science.
Right. If someone comes to you with something just so far-fetched, you would say, yes, I've heard that too.
Exactly.
And yeah.
Yeah, you can say things like, I've heard that a lot, people, wow, the last 3 people that came in said the same thing. There's lots of ways to validate an incorrect piece of information coming from the patient without telling them that they're wrong. And here's some examples. I hear that all the time. I can understand why you would think that. Lots of people have that question. My favorite, I was confused about that too, because I've done so much work with HPV and it keeps changing over the last 40 years. So it flip-flops. So I think it's very powerful when you can tell the patient, yeah, that you also were a bit confused about that. Anyone would find that hard to deal with. That's validation. Your feelings are exactly like we would expect them to be.
Yeah.
Many clients I see wonder about that too. And another one of my new favorites is, yeah, that's a great way to put it. I wouldn't have thought about it that way. It's a way to sort of turn it around. Pointing out straight-space positive. If the person tells you that they have just quit smoking and they're proud of that and you don't notice it, that's a miss.
Yeah.
Right?
Absolutely.
I'd feel bad if you didn't notice it, that I did something that I was really proud of.
Yeah.
So, but the point is we're not also complimenting them for doing what we told them to do. It's not like, oh, you're such a good patient. You did exactly what I told you to do. So just try to parse out the difference between complimenting somebody for doing what you told them to do and noticing and pointing out that they're doing something for their own health that matters to them.
Yeah, and it's that opportunity to build rapport, which then helps you get to the shared decision even faster.
These opportunities for building rapport are seconds in length, and they can save you so much time. And the point is for us to share information. I am not going into the room with the patient only to be nice and empathetic. That's all great. But my role is to be able to help them get the services that they need, get the information they need in order to get to the services that they need, get the information they need to be able to adhere to their treatment plan. But there's some things about sharing information that make it kind of difficult for me as the patient, get the information. You give me too much. You use words I can't understand. So instead, present information that's relevant to me and with a limited amount at one go. Okay, so this is a very basic concept about ASA cycles, is a quick affirmation, a really short, digestible. Remember the word digestible. You want me to digest this information you're giving me, then make it less than a mouthful. I can't digest, I can't get in too much information at one go. So before giving me more information, just ask a follow-up question, affirm again, and then more information. It's not that you need to limit the information altogether. You just need to give it in small doses.
Yeah.
And using the patient's words helps. Using numeracy like 5 out of 100 instead of 5% is really helpful. And I want to underline again, relevant information. Think about the things you tell patients and think about how much of the time do you say, well, if you were this, you'd have these options, but you're not that, so you don't have those options. Like, why did you just spend my time in the exam room talking about options that are not appropriate to me?
Yeah.
So ask yourself, what is the information that the patient really needs?
And I'm a chronic oversharer, I think, and that happens to me now that as a patient in medicine, that the clinician, and even though I'm a clinician, a lot of information comes at me. I'm kind of already stuck on the first thing that they were saying, and I don't know that I actually digested everything. And I realize that I have that same tendency with my own patients. So I think this is the hardest challenge for many clinicians.
Absolutely.
It's making the share small and then checking in to make sure that it was understood.
And it happens quickly. You can go right back into the next share, but what you've done is you've brought the patient into the conversation by asking them a follow-up question. You know that that piece of information landed, so you can give another piece of information. Other ways to get information into people's brains, into their hard drive, is with visual aids.
Yeah.
Very, very important when you're talking about something that can have a visual aid to use the visual aid along with the discussion. Same thing with tactile aids. If you're asking somebody to go ahead and you can go to the next one.
Yeah.
If you're asking somebody to use a method that is going to involve their dexterity, it would be a really good idea for them to play with it. If you're asking somebody to put something in their body, like an IUD or implant, let them feel what that is before they have it put into their body.
Yeah, that's great. And I love doing that actually for someone who's having their first pelvic exam. I will actually have them hold the speculum, I say, put your fist around it, and they'll say, okay, it's not as big as I thought it was going to be, but then it is going to expand. I let them know. But yes, tactile
really
is
great.
good.
Yeah, that's really good. So asking the follow-up question is one that's very, very, it's very valuable and it's not often done. So this is another one of those real pearls for you to remember. Anytime you give a little bit of information, think of what the best follow-up question would be. It should be related to the information you just gave them if possible. How did it land on the person? Did they understand it? Did they have other questions? So go to the next one.
Yep.
And the purpose of this is two things. The follow-up question is two things. It clarifies what informational needs they still have, what are their preferences for information, and it also helps them to integrate new information. By asking them the question, they are required to answer, and they will, in answering, engage. Because you can't answer a question with any kind of confidence unless you know what was just said to you that the question's about.
Yeah.
So that could look like lots of things, but again, as relevant as possible. So it could look like, you've just explained something, how would that be for you? Has that ever happened before? How did you manage it? Do you have a sense of how you would manage it? If that happened to you, do you have a sense of how you would manage it? Knowing that, how would it be? And more detailed and specific. The more detailed and specific, the better. So this is teach back, and probably everybody hates teach back because it seems really insulting to say to somebody, okay, now tell me what I just said to you. Unless that's your child and you're teaching them French, it's probably not a great, So what I do, and I think it works quite well, is to say, it's on me. I've given a lot of information. I'm not sure I've been clear. Just to be sure I've been clear, just to be sure I didn't forget to tell you something. So take it on yourself and then ask them, can you talk about what we said about how you're going to use NSAIDs or how you're going to use doxyPEP?
I think, and in this case, especially when there's a multi-step instructions that need to be followed in order, you know what I mean, to get the best outcome, then this type of thing is like, okay, I just want to make sure I covered everything. It's like when I order at the restaurant, did I get the order right myself? Do you know what I mean?
Exactly.
And I'm calling into the takeout order. You know what I mean? Read me back how many burritos I ordered and what was in all of them. So it's like that. Just, I want to make sure I didn't forget to tell you something because we covered a lot of material.
And maybe I wasn't as clear as I could have been.
Right.
And very simple switch. What questions do you have? So if you want the conversation to be over, then say, do you have any questions? If you want the conversation to continue and you want actually to elicit questions, what questions do you have?
Right, exactly. And sometimes you do need to cut it off.
You need to cut it off. So that's the right time to say, do you have any questions?
Exactly. Right. With one hand on the door.
With one hand on the door.
Exactly. Right.
So we're going to do a format where we're going to give you a case. I'm just going to talk about the science. Then we're going to give you some options for affirmations, options for the information to share, options for follow-up questions. But what we're going to do is demonstrate it. So we're not going to go into all the options. It's just to give you lots of an idea of what the options would be.
Yeah. And one thing I just want to put as a caveat is that if we were actually going to be counseling about any of these conditions, we might actually cover more content than you might actually see in the demo. So we just want to show you, this is really about a communication style and not necessarily like, oh, did they comprehensively cover every single side effect of doxycycline, for example? We're just giving you a sense of the way in which the ASA cycles and how quickly they could go. And we're actually going to ask Kelly Johnson, the nebulous Kelly Johnson behind the camera, to actually time our ASA cycles to get a sense of how long this actually takes. And also, one of us may say, let's stop it there.
Yeah.
And then we're going to sort of wrap it up. And then we'll also go into some tips and tricks or common pitfalls, if relevant to the scenario.
Absolutely.
Sound good?
Yeah.
All right, getting into it. Okay, so the case scenarios we're going to go over are someone coming in saying, oh, I want doxyPEP, someone coming in saying, I want a herpes test, and someone asking, is choking during sex okay? And we will have more background slides for this because I think quite a few people in the audience may not be as familiar with the practice of sexual choking and how prevalent it's become. And someone who you want to take a sexual history and they don't want to answer your questions.
Absolutely.
Uh-huh.
And we did try to pick, the reason we picked these scenarios is we thought that they were thorny.
Yeah.
They were things where you weren't just going to be saying, you know, the patient comes in, I've got chlamydia, I'd like a prescription, and you give it to them and they leave and you just tell them about the side effects. So these are things that might be challenging for you to have a conversation about. And that's why we chose these.
Yeah. And by the way, this is not rehearsed, and therefore we are just sitting here in the same room talking to each other.
Yep.
Basically.
And if we make mistakes, we might point it out.
Yes, absolutely. So that's why I should have taken a beta blocker today. So I didn't. That's okay though. We got this. We got this. Patty, we're pros. We're pros. Okay, so let's talk about doxyPEP.
Let's talk about doxyPEP.
Go ahead, Patty.
All right. So Marissa, I'm going to be Marissa. Marissa is a cis female who occasionally receives money in exchange for sex. She's had condomless oral and vaginal sex with multiple partners in the past 3 months. She had syphilis last year and was treated with penicillin and had an appropriate titer response. She's heard about doxyPEP on social media and she's coming in requesting a prescription. I already did that. I've already.
Yeah, so just imagine she's already done that. And so here I come in with some data on doxyPEP. So the issue with doxyPEP in cisgender women is that we don't know if it works, but we do know that it works really well in men who have sex with men and transgender women who have sex with men. So I'm going to level set us for every single scenario. So I know many of you know this, but the efficacy against chlamydia in these 3 randomized trials that included MSM and transgender women was 70 to 80% for chlamydia and syphilis, which is fantastic. And 50%, 57% for gonorrhea. That was in the US only. And in fact, in France, it didn't work because of very high levels of tetracycline resistance to gonorrhea. So there is one published study in cisgender women which found no difference. The issue primarily in that study was that women didn't adhere. So when they took some hair samples from some of the people in the study, about less than a third of the hair samples actually had doxy metabolites, which means people just didn't take it. So, you know, I think we don't know for certain if it works in cisgender women, but I suspect it probably works if you take it. And I'm just going to share with folks in the audience who may not have been at this meeting in Montreal last summer, is that Janelle Stewart, who published that first New England Journal study, did do a small pilot follow-up study that's not yet published called DoxyDot, or Doxy Directly Observed Therapy, is that they gave it once a week, and they did find that it reduced the combined outcome of gonorrhea and chlamydia. So that may give you some more information to think like, well, if people take it, it might work regardless of sex assigned at birth. So the other issue is that the CDC guidelines just recommend use of doxyPEP in men who have sex with men and transgender women right now. And so some states, including the state of California, where we happen to be sitting, do have more permissive guidelines recommending shared decision-making for cis women. And some jurisdictions say, don't use it. Do you know what I mean? In these populations for which there are not yet published data. So that's where we find ourselves. And so Marissa has come to me saying that she's heard about doxyPEP on social media, and I could pick any one of these affirmations or acknowledge options. And I'm going to pick actually number 2, I think, but really any of these could be used. I'll just read them. I can see it's important to you to protect yourself by doing what you can to prevent STIs, or I'm so glad you heard about doxyPEP. I think you're right. It's good for us to talk about. And wow, you're really informed about ways to prevent STIs. 3 examples. You do you, and in terms of what you would say, but Patty and I are just going to talk for a moment about doxyPEP, and I'll do some of what I would ordinarily do in a patient interaction. And I've actually done this with a patient very much like Marissa. And then we'll ask Kelly to time us and see how long that takes.
And when we have the affirms, I'm going to give you a sense of whether this is empathy, whether this is agreement. So look, you can see, I can see it's important for you to protect yourself. Okay, so that is pointing out a health supporting behavior. Okay. Second one, I'm glad you've heard about doxyPEP. I think you're right. That's agreement. Third one, wow, you're really informed. Again, it's pointing out a strengths-based positive.
Yeah. So Marissa, I'm really glad you've heard about doxyPEP. I actually think it's a good option for us to discuss. Can I tell you some more?
Yeah, I'd love that.
Yeah. So, we don't know for sure whether or not doxyPEP works very well in women because there haven't been a lot of studies, but the antibiotic's been around for a long time, and I think it's pretty safe, and it could actually help you prevent STIs in addition to what you're already doing in terms of condom use. Can I tell you a little bit more about how to take it? Or do you want to know anything else?
Yeah, but I mean, it sounds like maybe it's not, it sounds like maybe women, it's not supposed to be used in women.
Well, so that's a good question. There isn't anybody who recommends its use, broadly in women, but the thing is that this drug has been around for more than 50 years, so it certainly can be used in women, and women use it for things like acne or other infections, like skin infections. So
I'm going to stop this for a second.
yes.
Were there affirmations after I've answered your questions? And was that too much information that she was giving me on a share? Right. I'm going to say maybe it was.
Yeah, so maybe it was.
Okay, maybe it was.
So yeah, that's the thing is that we want to point out, like, I think I have a tendency to overshare. So I could have just said, it's an option that could work for you. Doxycycline's been around a long time. Would you like to hear more about how to use it?
Or have I ever used it? Yeah. Have I ever used doxycycline? How did I do with it? Right. So now you're getting history, plus you're asking a follow-up question. Yeah. Very efficient.
Yeah.
Because you really do want to know if I know about it. Why would you bother to tell me about doxy if I was on it for 10 years for my acne?
Yeah. Yeah. So have you ever taken doxycycline?
I actually have quite a number of times.
Oh, and how was it for you?
It was fine. They told me that it was going to make me really get sunburned, and I never had that happen to me.
Well, that's great. You're lucky.
Anyway, I was fine. Yeah.
That's great. You're really lucky. Would you like me to tell you about how to use it for protection against STIs?
Yeah, that's exactly what I would like. That's what's really freaking me out.
Okay. Okay, great. I can hear that you're concerned about it. Can I show you? I have a little sheet here that shows us how you would actually take it. Would you like me to go over it with you?
Sure.
Okay.
So this is, you can see the affirmation makes a difference, right? Yeah. And she's cutting it up into more small digestible chunks, the share.
Yeah. Okay.
So next time we will get, let's keep going, and then we can next time get Kelly to, do you want to do another one on a different one? And then with this, and then we'll have Kelly time us.
Oh, you mean do another affirmation? Yeah, sure, absolutely.
We're going to start again.
Yes,
we're starting from the beginning.
Yes, we're going to start again.
Oh, wait. Okay. So sorry, everyone. I should stop the timer. You're currently 1 minute and almost 30 seconds.
Okay. So,
but that wasn't fair because we were talking to the camera. We were.
Oh, I paused it. I paused it.
But right now we're going to start. So now, Kelly, start.
Yeah. Okay. Go.
So I'm glad you were able to get a lot of information online about how to protect yourself from STIs. So doxycycline is an antibiotic we've used for a long time for all kinds of conditions, and we're starting to use it. It's an option that could be good for you. Do you want to hear more?
Yeah. I'd love to.
And I'm just curious, have you ever taken doxycycline?
I have several times. Actually, I was on it for a really long time when I was a kid.
Oh, well, that's great. How was it for you?
It was fine. They told me that I was going to get a sunburn, but I never did.
Oh, well, that's fantastic. It's a little bit different in terms of how you use it for protection against STIs. Do you want me to go over that with you?
Yes, that'd be great.
Okay. So here's a little sheet that I show to all of my patients. And I just wanted to point out that, you have to take 200 milligrams, so that's 2 pills, and you take it within 72 hours after the last time that you had sex without a condom. So that could be oral, vaginal, or anal. Does that make sense so far?
Yeah, definitely. Can I take it before if I know?
No, that's not how it's supposed to be used, but I'm glad you're thinking that way.
So she had a no. She could have switched that to a yes, right?
Right. I'd say
great thought.
Great thought.
What a great thought. You're trying to prepare.
Right.
You're really thinking ahead.
Exactly.
Okay, let's move on because I'm worried we're going to not get to the
end. Yes.
How long was it, Kelly?
Total time, 1 minute, 7 seconds, 17 milliseconds.
So our first set of ASAs was an hour and 30 minutes, 1 minute and 30 seconds, which because Kelly paused it actually when you started talking.
Good.
And so then the next round of ASAs was about a minute. So I think that, the thing that is most difficult is that my strong temptation, even though I'm giving a webinar on shared decision making, is to give much more information. And it's often too much for the person who's receiving it. And unless they are also a clinician and they're asking very specific questions about studies or data, most of the time, I'm probably sharing too much.
I am too.
Yeah.
And I think as much as possible, taking your cues from that follow-up question, taking your cues from what I'm telling you I need and want.
Yeah.
That's how I most effectively cut down the amount of information at one go, is by responding to the patient's query.
Yeah.
Really trying to get to the bottom of what do they really need to know.
Yeah. And so just so you know that the ASA cycles would also include demonstrating how to take doxyPEP and then asking back. And then I would do side effects separately as separate ASAs for sun sensitivity, for what medication you can or can't take with doxyPEP. And so again, and then for pill esophagitis in terms of instructing people not to lay down within 30 minutes of taking doxyPEP. So just to point out, each of those side effects should be a separate ASA.
A separate ASA.
But I have often been giving them all three at the same time. And I know that people are not retaining it necessarily. So, so here are some share options. Is that there's a lot of information about doxyPEP, right? You can tell people how to use it. You can tell people that there are data in MSM and transgender women and not much known about what's going on in cis women. You could mention that there was a poor adherence in one study with cis women and that more studies are ongoing. Or you could even mention there's no guidance for use in cis women. These are just things that you could mention, but we're going to ask you what you think is most relevant. And then obviously you can share what your recommendation would be about whether or not to use it for this particular patient. So just a polling question for this patient, and just a reminder, it's she has had condomless sex. It sounds like she does some exchange of sex for money. She had syphilis in the last year. And again, which of these do you think is sort of most relevant to her? Would it be just giving her the information on how to take it, the data in MSM and transgender women, the poor adherence experienced by women, or to mention that there's not guidance, but we could use it on a case-by-case basis, or your recommendation? What do you think is the most important thing for you to share?
And the reason that it's really good to know what the most important thing is, it's not that you're only going to give that information. You might end up giving all of this information if that's what the patient really wants to know. But the reason it's really good to know what's the most important is that that's what you're going to start with most of the time, because as Ina pointed out, that's probably what the person's going to most easily remember is the first thing.
Yeah, the first thing and the last thing are the things that they're going to remember the most. So,
yeah. But if you do the ASA cycles, you have a much better chance of all the things in the middle getting eaten up too.
That's right. So what do you all think in the audience? The poll is going and I can't vote, so we're going to have to see what you think.
I'm going to I will point out the no guidance for use in cis women could be done on a case-by-case basis. So the term guidance is meaningful to clinicians. It's not meaningful to patients, right? They don't care about the guidelines. I mean, unless they do. And then
people do, but yeah,
some people do.
A lot of people don't.
It's certainly not it's not the moving force for them.
Yeah. But I think the most important piece is that you were willing to consider on a case-by-case basis.
The case-by-case basis, that's super important.
What did we have for our responses? Ooh, people are all over the place, but people were most enthusiastic about needing to just share the information on doxyPEP.
Yeah, absolutely.
And then after that, the next was that this could be done on a case-by-case basis.
Absolutely.
So that's great. And honestly, you might say all of these things, but I think people were most likely to point out the data on MSM and trans women is not actually necessarily relevant.
It's not relevant. Exactly. And you can say we don't have as much data as we would like, and some of it is even unpublished. And I think in your case, it's really probably a very good idea.
Yeah. So out of these, if you were pressed for time, what do you think that you would leave out? You would try to talk about everything. You would, and just so you know, I'm guilty, by the way, of talking about all of these things. And so do you think the data in MSM could be omitted? The poor adherence in women could be omitted, the lack of guidance in women, or should your
I
recommendation?
guess you could guess that your recommendation should not be omitted, right?
Yes.
Because we've just said this like 20 times.
But what do you think, like in that interaction, what could be omitted?
And it's not that it should be omitted, it's that it could be omitted because one Marissa might really, really want to know all the
Right.
facts, right? Everything that's known anyway, in language that she can understand and words that she knows the meaning of. And another Marissa's like, I want to know what you think I should do. Like,
Right.
and what do you think? Do you think this will work for me? And Ina does think it will work for her. And that's
Right.
a reasonable question to answer because
Yeah.
she's asked you that specific question.
Okay, let's see the results.
They said,
What did they say? Okay, so the poor adherence, it's between the poor adherence and the data in MSM and transgender women.
and that's right.
So I think that's great.
I would have said the exact same thing. So that's great.
Yeah. Okay, so as a clinician, remembering during the ASA cycles, you may have seen me saying, do you want to hear more? And then these are just examples of what you could say
Instead of, would you like to hear more?
right.
Yeah.
And then also like the open-ended, what questions do you have? And when we're getting now to the end of the ASA cycles where you're like, it's clear that we're going in that direction, but asking number one, does that actually sound like that would work for you?
Yes, very good idea. Asking whether something that you're talking about as a treatment plan might work for somebody is something that gets left out a lot of the time. And instead of doing the entire visit and then asking at the end, ask every time there's something that requires their involvement, like they have to actually take the 2 pills.
Right.
Right? Does that sound like it's something that would work for you, that you can get a hold of of the bottle within 72 hours after you've had a sexual encounter?
And number 3, I just want to point out is something that I don't do enough, is that I give the details without asking, like, do you actually want the details? Because some people are like, not really. Some people just say, I heard
I'm going to forget what you're going to say anyway.
Just give it to me.
Yeah.
So, but some people do really love the details and it's good to ask. So I think this gets into discussion question that we had was, well, what if this is a patient who you don't think is a great candidate for doxyPEP, with one mutually monogamous partner who never had an STI, and you really don't want to prescribe it for that person, then you're
very different scenario.
Very, very different scenario. And all of us have had that experience before. But again, digestible. I think if you come away with any word, the one thing you learn is just keep it digestible. And we already talked about what's the most relevant piece of information, that you want to lead with first. And what do they actually need to know to make an informed decision? And sometimes people want to know extra details and sometimes they don't. But asking if they want the extra detail is good.
And, the knowing in yourself, in your own mind, knowing what you think is the critical piece of information that's going to make the difference between them knowing what they need to know and not knowing what they really need to know, you having that piece of information in your own mind will really make the visit go more quickly. It's going to give you so much more time in the visit than you would have had otherwise. And it seems crazy, but once you give that little piece of information, that's the exact piece of information, it's like a key in a lock.
Yeah.
And the person all of a sudden is like, oh, they got it.
So now we're going to talk a little bit about herpes testing.
Didn't you have pitfalls?
It's just keeping it digestible. Yeah.
We already talked about this.
Yep. So now we're going to talk about herpes testing.
So Maya reports that her best friend just had his first genital herpes outbreak, and it was severe and it was painful. None of the friend's prior partners had a history of herpes, and therefore the diagnosis came as a shock to him. After seeing her friend suffer, Maya has been very stressed and is worried that she might have asymptomatic STIs, including herpes. She asked to be tested for everything, and especially a blood test for HSV. She's never been diagnosed with an STI. And as an older clinician, I will tell you that when HIV first came out, it was like, thank God it's taking the pressure off of herpes.
Right.
For those of you who are younger, it was quite a frustrating thing for clinicians at that time in the 70s and 80s.
So I just want to point out that just to level set us again around the science is that HSV serology testing is not really recommended for STI screening among the general population by the CDC. And that is because it has serious limitations. It is recommended for certain populations. Sometimes people come to you saying, oh, someone diagnosed with herpes, they've never actually had any laboratory confirmation. People have recurrent genital symptoms, but never gotten a diagnosis. People in a serodiscordant partnership, possibly. And so this is my favorite of the studies that actually looks at the true test performance of the herpes immunoassay, followed by a Western blot, which is the gold standard done at University of Washington. The HSV1 test is not very sensitive. The specificity is not too bad, 91%, but the HSV2 test, the sensitivity is around 92%, but its specificity is 57%. And for low positive herpes results, it's actually 40%. So it's essentially, I would say, a worthless test if you have a low positive result and can give a lot of false positives, particularly in folks who have a history of oral HSV1 or HSV1 in general. So just want to level set that.
And so I'm hearing that the really only benefit to the test is that you will get a negative that you can believe.
Right. That's correct. And that's one way you can phrase it to the patient as well. But I think we're just going to do a few ASA cycles. I'm going to start with an affirmation because Maya's just told me about this terrible thing that happened to her friend.
Well, let's go through them. So the
them.
First one, it's empathy,
Yep.
right? Looks like you've been doing a great job. So that's pointing out health supporting behavior.
Mm-hmm.
Wow, I'm sorry your friend has been suffering like this. So I said earlier that if somebody expresses an emotion of some kind and you don't notice it, that's really a mess. It could damage rapport. In a normal social environment, if somebody says something that's emotional like that, you give a quick response, right? So when it comes to this, wow, I'm so sorry your friend has been suffering, I wanted to point this one out specifically because if the person tells you something that happened to their friend, in this case, the friend just got herpes, but let's say they said their friend had something very weird happen that medically is really pretty much impossible or very, very unlikely, you would still, wow, I'm so sorry your friend had that happen. Well, I can tell you, I haven't heard that before, and I can tell you it's definitely not something that happens much.
Mm-hmm.
It's really not common. So it's a way to give the information without insulting the person about their friend.
I think personally, I would probably lead with, so if we can start now, Kelly, mm-hmm. I would probably lead with, that sounds really stressful. I can see why you know that if you have herpes. I just want to reassure you that after we talk about this, if you want the test, I will order it for you today. My concern about the test, though, is that it gives a lot of false positives. And so oftentimes when we get a result back, half the time or more than half the time, we can't believe it. So how would that be for you if you might get a result that you possibly couldn't have confidence in?
But why would it say I have herpes if I don't have herpes?
For some reason, this test gives a lot of false positives, especially in people who might have oral.
Was that a good question that I asked?
What do you mean?
I didn't get an affirmation that my good question. I thought I asked such a good question.
That's a great question, Patty.
That's such a good question.
That's a great question, Patty. The reason why it gives false positives, maybe because when people have cold sores or other forms of herpes, it may trigger a false positive result in this other test. And so
I've never had a cold sore.
Well, that's great. But I'm asking you how you would feel about.
I think if that's really true, I would be extremely anxious.
Well, so
I've never had an STI. And if I got a test that told me I had an STI and I wouldn't even know, you're saying I wouldn't even know that it was right?
That's right.
Why do you do the test?
Well, we only do it in very select circumstances. I'm first of all, I'm really glad you asked that. And we test in very selective circumstances. And this is not typically the circumstance that I would do it in. But again, I also want you to come out of here feeling reassured about your status. So
do I know what my status is? Do I know what that means?
Well, so if she asked me, what do you mean?
I'm just making it really hard for you.
I'll clarify. No, but I want to come back to,
but those kinds of phrases that we use, like your status, a lot of people would have no idea what that meant. Your herpes status, they wouldn't know what is it. I thought when you got herpes, it was a bad thing. I didn't know it gave you status.
Yeah. Right, exactly. Right. Status can mean multiple things to multiple people. But I think what I would ask you as a clinician is it okay if I tell you about an alternative test that I think is much better?
I would love that.
Okay, great.
So there you have, I think we could stop it there.
Yeah, we can
right?
stop it there. So I would tell her about the, PCR test if she ended up having a genital lesion and talk about how that test is much better and I have much more confidence in it. Kelly, how long was our sort of banter?
Just about 2 minutes, a little over.
And we got pretty much all of it done twice because you basically did it 2 different times in 2 different ways. That was great.
I think the point is that this doesn't have to take 20 minutes. And that's the other thing that I worry about, especially with this particular can of worms, is that it's going to put you behind.
Yes.
And again, now some patients are not going to, they're going to want to perseverate and talk more about it. But I just want to point out that you can do these ASA cycles in 2 minutes, 3 minutes, even 1 minute, sometimes
30 seconds.
Yeah.
Yeah.
So these are some of the shares. I don't know if we have a poll for this. We'll just have to say, I want to just point out that I led with, I will order this test if you want me to, but then we talked about why it would not be a good idea, right? And so some of the options that we talked about were the high likelihood of false positives and possibly falsely diagnosing someone with a chronic STI, providing the alternative test with better performance characteristics, explaining, sometimes, you're explaining the differences between serology for HSV1 and HSV2.
Which I personally would want to stay away from. And I think all of us would want to stay away from that conversation if we could.
Right. And sometimes the conversation gets into the natural history. This is when it's becoming the 20-minute conversation.
Exactly.
So these are just options for things that you could share. And I do think we have a poll. So I'm curious, what are the most what, in this case, we're asking what information in a herpes counseling session do you think that you could omit?
In this case, for this patient, for somebody who has no reason to think she ever had herpes.
Right. But is just freaked out because her friend has herpes.
Whom she's never had sex with.
Right. Yes, we should establish that.
Did
you have sex with this?
Did you have sex with that friend that was so?
Let's assume they didn't. So let's see what people say. What information could we omit from a counseling session?
The affirmations that we all forget all so much of the time because it doesn't seem relevant, right? The information that we're sharing seems relevant, not that affirmation. So, but those affirmations, I'm still going to posit are going to be saving time.
Yeah.
Because I, as the patient, and even though I'm doing a role play, when she told me that she was going to give me the test if I want the test, I actually felt relieved.
That's great.
Which is kind of weird.
Even though you decided in the end not to get it. But so how's our poll doing? What did people think could be omitted from the counseling session? The difference between HSV1 and HSV2, as well as the natural history. Those are the two top two. And I agree with you completely. So here's some example of asks. I chose number 2, but you could say number 1, you want to hear more about testing. How would it be for you?
You also did 3 with your second or third ASA sample.
Yeah. So I think these are just options for ways that you can ask. And again, actually, sometimes asking more often somehow paradoxically shortens the interaction.
It's really weird, but it does. And this follow-up, the 4th bullet point is super important. Your follow-up questions can be right? The history taking that is relevant to the thing you just said. You will have asked about drug allergies, but it's reasonable if somebody is going to be given doxycycline, as we did in the last scenario, to ask if they've ever taken it before and what happened to them.
Right. And this whole question about whether or not the person's had cold sores is that if they do have a history of HSV1, then it makes it even more likely that they'll get the false on the serology.
Yeah.
But
so you could say these false positives are
even more
50% of the time, the test, if it says that you have herpes, about 50% of the time it's wrong.
Right. Especially in folks who have a history of HSV1. But
exactly.
For this audience, so I just wanted to say that there are newer serology tests that I think will be written. We're discussing them for the guidelines, and there's a lot better tests actually that are FDA approved now. So fingers crossed, everybody, for better herpes serology. So some tips, which I have learned actually in this process for preparing for this webinar, is the affirmation or acknowledgement can be very short. One word. Yeah. Wow. Yeah. Great. Like, one time I just said great. That's your affirmation. One word.
Or you're on it.
Yeah. So that's it. And then give your recommendation. Remember, your recommendation is fine. I recommend that, patients in your scenario do not use this test, and that's fine to say that. And so another tip and trick is if you're willing to order the test in certain circumstances, especially if someone's really anxious, I'll say, let me just reassure you, we can order this if you want it, but let me tell you why it may or may not be a good idea. But I lead with, I will do this if you want me to. But if you're not, you say, I'm sorry,
If you're not willing to give it, don't say that you,
Yeah.
say that you are.
yeah. And say like, I can see this is really important to you. I do not prescribe ivermectin for COVID, something like that. And
I can see why you'd really want something that would be able to help you in this situation.
Yeah, but I'm really sorry I don't do that.
Yeah.
Or our policy here is that we actually only, this happens all the time. Only Medi-Cal patients can qualify for this, and patients who are insured, we can't give this. That kind of stuff unfortunately happens all the time. Okay. So now we're going to talk about sexual choking. This is a tough topic and one that maybe folks are not as familiar with. So so Sarai, I'm gonna be Sarai, and her partner engage in sexual choking, which is consensual. And the patient enjoys it most of the time because it's intensified her orgasms, but she's been having some blurred vision and headaches after she has sex, and there's choking involved, and she's never lost consciousness. I will come back to that part later. And she's asking today whether or not it's safe, whether choking is okay, and whether she should or can continue. And so I'm just curious for folks out there because you'll see that this topic is more relevant, I think, to folks who are seeing younger patients, the under 25 folks. But I just want to hear if anyone out there has had a client or patient disclose a history of sexual choking, consensual or not. So let's see.
I've started to notice in media, like movies and stuff, that when there's a sex scene, there's frequently a hand that comes to make a suggestion of it. Like it looks like that's where it's going.
Where's our poll at, folks? Okay, so 25% yes and 70% no.
Fascinating.
It is fascinating. And I have to say that it's not something that routinely is asked in our intake. And I'm not sure about other folks' intakes. We do ask about intimate partner violence, but do not ask about consensual choking in ours. But so about 25% of folks have had a client disclose this to them. And I just want to point out that it's actually a pretty common practice. And you'll see that what you've reported is actually similar to what's being said out there. So you'll notice that all of these citations are by the same investigator. Her name is Debbie Herbenik from Indiana University. She is the greatest of all time, or the GOAT.
So wonderful.
Of if sexual choking, if that's a dubious distinction, I'm sure she'd wear that with pride. She published this year a analysis of the National Survey of Health and Behavior, which covers folks 18 to 94. And so they divided the data in different age groups, but about over a third of women under 40 reported being the recipient or the chokee of sexual choking, and 8 to 18% of men under age 50 with, so that's almost a 1 in 5. And that 1 in 5 was most common for younger men, the under 30s. And so she also has done a lot of work with undergraduates at university. And so the campus sexual health survey that was done, which is a representative sample of all the undergraduates, almost 5,000, 43 had reported choking a partner during sex, and 48% had been choked by their partner.
That's a lot.
It's a lot of choking.
It's a lot of choking.
And so that's why it's part of, I know we're doing ASA cycles, but I just wanted to take this moment to have a moment of education for all of us about how sexual practices are changing amongst our younger clients, our younger adult clients. It is more commonly reported among sexual and gender minority populations in her undergraduate study.
And way more frequent in heterosexual parents for the female to be choked and the male to be the choker.
That's right. And Another analysis of one of the citations that I had earlier by Debbie, here's the effects that people experience with choking. So 82% said that they felt some sort of pleasure or euphoria. And a lot of that can be due to the next item, which is a head rush that results. And also, if you think about it, holding your breath does shunt more blood to the genital area. So that I could imagine could be part of it. Unfortunately, 39% or 40% reported difficulty swallowing after having been choked, being unable to speak, having visible neck bruising after the event, and 3%.
That is so significant. 15% with neck bruising.
Right, which means
if the neck is bruised, they've been strangled.
Right. So that's the amount of pressure, right, that you can think about being put in the interaction. And 3% lost consciousness, which we know is a response to hypoxia. So I just want to take a breath with that and just point out that, yeah, this is a practice that I think many of us as clinicians would be really concerned about danger and serious health harms. I want to go over a couple more data slides. Sorry.
No, I think
I had to take the minute to do that. So these two investigators, Huibretsky and Bichard, also the senior author is Debbie Herbenik again. They did a cross-sectional study doing blood draws on women who had been choked 4 or more times versus women who had never been choked, and found inflammatory biomarkers as being elevated in young women who had been choked 4 or more times per month. And then a systematic review of non-fatal choking. So this is involved primarily domestic and sexual violence cases. So obviously that's different than consensual choking, but maybe with the neck bruising, maybe not.
Neck bruising, loss of consciousness.
So obviously there can be negative outcomes, arterial dissection of the carotid, stroke, seizures. I can't even read that's behind my Zoom box. Sorry. Speech disorders and paralysis. It's motor and speech disorders and paralysis. Sorry, I had to move my camera. None of which we want our patients to experience. And this is my last thing, because this is important for us. The 25% of you who said that they've had a patient report choking to you, what are the messages that actually make people less likely to participate in this behavior in the future? So again, Debbie, this was just published 3 months ago, I think in November. Again, a group of 973 college students who she presented different combinations of different educational messages to. And those messages were on consent, which is that actually you can't actually consent to being harmed. So you can't say, Patty, shoot me. Right. And if you shoot me, you're still actually, I didn't actually consent to that. So also, she presented the physical and mental health consequences of choking. We talked about the physical consequences. It's also been linked to a history of anxiety and depression.
Yeah, those were very significant data. And I think that given the mental health problems with a lot of our youth right now in this moment, I think that's a critical piece to share with patients.
Yeah. And just by the way, the most common age was that people heard about choking around age 15. So, and then also the potential legal consequences of choking, meaning prison time for assault, etc. So females who had previously been choked, who received any of the messages, any type of content around negative consequences, report that they would be less likely to participate in choking in the future. But for males, so these were cisgender males in the study,
the chokers,
who'd previously either been choked or choked a partner, said that they would be less likely to participate in the behavior only if the legal consequences message was included. So when she tried different combinations, you have to include the legal consequences for at least the male students to feel like they would be less likely. So the fear of that, just wanted to put that on the table.
Yep.
So now we're going to go into an ASA cycle. Patty is going to go over some of these affirm. And we're doing great on time, by the way. So
good. So you're right to be concerned. That's agreement. Choking's become more commonplace lately, so you're certainly not alone in wondering about this. So that's validation. I've been hearing the same thing from my patients quite a bit. Validation. It sounds like there are parts of this experience of choking that are really enjoyable for you. That's basically mirroring back what she said. That's not one of the 4 that we have, but you could put it sort of in the empathy category because she's got pleasure that she's talking about. Okay.
Yeah. So You want to pick an affirmation, Patty?
Um,
Kelly, start timing.
yeah. Wait,
Um,
we're supposed to be at the, oh,
Affirm.
did you put it to the share, the other ones? I thought it stayed on the affirm.
No, it should. I messed that up.
Oh, okay.
It should stay on affirm.
Okay. I would actually combine 1 and 2. I'm so glad that you brought this up. Yeah, I can see that sometimes this has been really pleasurable for you, and it's something we probably should talk about because you're right. Headaches and blurred vision can be really concerning. So the first thing I want to tell you is something I wish I had other news, which is that there is not actually any safe way to be choked. I can see that's landing. How's that landing on you?
I mean, I feel really conflicted because I was suspecting that because the last time I just felt really weird afterwards. And I just asked myself, like, is this actually good for me? And I guess I just needed, there's people online who say that it's fine. Like there's actually quite a few people who say like, here's how to do it safely. But after the last time I had sex, I just needed to ask somebody else about it that wasn't like an online influencer.
I'm so glad you did. It seems like you're really paying a lot of attention to the details and the science around this. The thing that you were describing with the blurred vision and headaches, that's a direct consequence of lack of oxygen going to your brain.
Yeah, I'm definitely hearing that message.
How long did it last?
Like probably like a good 10 minutes where I just felt really off.
That sounds scary. That
Yeah.
sounds scary. Would you like to hear more about some of the things that it does, or is that going to be overwhelming?
No,
I don't want to scare you.
No, I think I know that it's probably not good for me, but like my partner are kind of into it. So
yeah, I hear it. It's not easy.
Is there anything, I don't know, is there anything else I could do instead?
Yeah, there's some things we could try. Yeah, it's a really good point. When you're having something that's hard like this, to come up with something that actually is an alternative is a great idea. It depends. I mean, if the pleasure that you're getting is because you experience a better orgasm, you could probably hold your own breath. You could probably bear down and try to get all the blood in your body to be more concentrated in that area. That's one thing that you can do. How would that be for you?
I think that's something we could try. You want to just cut off here? So we could go on, but Kelly,
the other thing I was going to suggest, now we've cut off the time, but I was going to say another thing is if she had said that the thing that she's into is the kink part of it, the power over, that she enjoys the fact that he has power over her, then there's a lot of faux you could kind of pretend to go really close, but not actually strangle.
Yeah. Kelly?
224.
224. So,
and that was pretty much everything.
Yeah, that's a lot. And
because we did several cycles.
Yeah, we did several cycles, and I definitely got a lot of affirmations from you. And I think, one thing that you mentioned twice, which I thought was actually fine in the share, was that the headache and blurry vision is related to lack of oxygen to the brain. Yeah. And so I got that message loud and clear. And so I'm not saying everyone out there is going to be like, okay, now I can go counsel on sexual choking right away, but I felt like we should bring it up.
Yeah, and I think the other thing is that people are not probably bringing it up to you because clearly 75% of you have not had anybody bring this up to you. So if 50% of the youth are doing this and you're not hearing about it, then clearly they aren't concerned. They're not coming in with the question.
Right.
So a lot of these conversations are going to be history taking. You find out it's happening, then you have to segue into the conversation, and an ASA cycle will really help with that because we're talking about somebody who's not even coming in questioning it.
Yeah. And by the way, when you get your evaluation, if this is something that you want to hear more about, and also maybe how college health providers are or aren't responding to this, put it in your evaluation, and we'll see if Debbie Herbenick can come and talk with us. But
that would be the best thing in the whole world.
Yeah. So I think, from the medical standpoint, like one thing that you did well, Patty, was you just acknowledge that choking can cause pleasure. And that, if you guys remember the data slide, is that some people, 82% of people said that they had either pleasure or euphoria, and that's why people are doing it. Now, why they started could be because it's modeled in porn or whatever, but people do things that cause pleasure. And so I think it's fine also to say, well, some people don't have issues, but there can be serious consequences. And
And
that
I would say not that some people don't have issues, they may not experience the issue at the time.
right.
But that
Because you
doesn't mean
can
it's
have
not
delayed,
possible.
yeah, you can have delayed effects, right, on mental health. So, and then presenting an alternative or harm reduction approach which I specifically asked for as the client, well, what else could I do? Do you know?
And your clients might not.
Right.
And so you might say, can we explore some other things that I found my patients have said work really well for them?
Right. And I specifically, as the client, did not want to discuss all the serious consequences because I knew
Yeah.
even just with what you
So I
had
asked
said.
her, does she want to hear all the gruesome details? And she didn't.
Right. So in terms of, now the follow-up ask, which definitely, Patty did, is like, what was it about the experience that I was most interested in? Was it around the pleasure, specifically around orgasm, or was it around, if it's a power dynamic thing, there are other ways that you can engage in power play. But anyways,
and if it's the head rush, hold your breath.
Hold your own breath.
Hold your
right.
own breath.
So I won't go into all of these asks because I want to leave some time for questions.
But notice that these are asks that are very specific to the particular person that we're talking to. It's not really a generic ask, and they're specific to the content that you just covered in the share.
Right. So I just wanted to point out is that, doing sexual health care challenges our biases and our judgments, because as soon as I started hearing about sexual choking, immediately like all my alarms went off.
I'm wondering, ask yourselves how that feels.
Yeah.
Right? Yeah.
Which is different than if someone comes to me and says, like, I have a family history of high cholesterol or I have hypertension.
That's terrible.
I know, you know what I mean? Well, I don't have as much judgment around it. And so I think with sexual choking, this behavior is new to many of us. And when people are engaged in behaviors that we think are sort of high risk for negative consequences, we get reactions. And so, and any behavior, when people say I had, a huge number of partners, you think, okay, this might increase your STI and HIV risk. And so you have to talk about these things that are new to you that maybe you don't necessarily want to engage in yourself and that you might think could be harmful. So this is a very difficult topic, and thank you for being here with us to talk about it. And let's do a very brief.
We're going to be very brief on the sexual history because
Yes.
it doesn't have to be long, and we would like to get your questions.
So Jonah, that's me, came in for an ankle sprain, and the visit's almost over. And
I'm walking out the door.
And I say, by the way, can I get STI and HIV testing today?
Which probably, I would say, for two reasons, probably triggers a lot of clinicians' buttons, because the patient said, I will order. A lot of clinicians are like, well, excuse me, you're not ordering that.
Right.
So just check with yourself when you hear those sorts of things, whether your little hackles get up.
Yeah.
The other thing is that we don't like questions that might end up taking a lot of time when our hands are on the doorknob. Okay, so sexual history taking. Everybody knows about the 5 Ps that's in the CDC guidelines from the sexually transmitted infection treatment guidelines.
Mm-hmm.
The partners, it's not about gender. It's about what body parts the person has. So in the CDC guidelines, it's talking about body parts. What body parts do you use when you have sex? What body parts do your partner or partners use, and where do they go? What do you do with them?
Right.
And that's really the very critical thing in terms of knowing how to test and what to look for.
And what goes where. So we won't go over the 5 Ps.
Except the last one's pregnancy intention, which is the PATH questions.
Yes. And we are going to include those slides with the PATH framework around how to ask around pregnancy intention, but we won't go into that today. So we're going to
just look at these questions, right?
Yep.
Those are the questions. Do you think you might like to have more children? Hey, you know what? We're going to do it really quickly. Do you think you'd like to have more children at some point, Ina?
Definitely not.
How important is it to develop pregnancy?
Extremely important.
There you go. That was the pregnancy intention. Thank you.
Yes. So these were just including for you just as a resource. We're actually never planned to go over them. We just wanted to include them. So the polling question.
I think it's the last one.
Yes. What information do you actually need to proceed with the rest of this visit? I just asked you for STI testing and HIV testing after you've helped me with my ankle sprain and you want to get out of here. But what do you need to know? Number of partners, number of lifetime partners, number of current partners, identify gender, what body parts go where, or none of the above.
It's a bit of a trick question.
It's a bit of a trick
It is a
question.
bit of a
What
trick.
do our polling folks say? What body parts go where? Okay. And you know what? You can actually do this visit with no information, and we're going to show you how.
That's right. Because you know what? I need the information so that I know which tests to order, right? And where to get those tests from, what part of the body. What if my patient knows that information? Maybe a lot of our patients know that information a lot of the time. Maybe we can give them information like, well, we would need to get a rectal swab if you had had penis in rectum sex that you were the recipient of. Then they can tell us what tests they need. They don't have to tell us their practices. But anyway, so here's the affirmations.
Affirmations, yeah.
Yes, I can see it's important to you to protect yourself. Again, health supporting behavior. Many people feel like answering questions about their sex life is not comfortable. And that can either be as a prelude to asking sexual history questions or in response to this particular person not being comfortable.
Mm-hmm.
The person's just said what they want. I am going to find out how much do they know pretty quickly. Am I right that you're pretty familiar with STI testing? Now that's a question, but it's also an affirmation because it's pointing out their knowledge base.
Right.
Right. You could also say, it sounds like you're pretty familiar with STI testing.
Yeah.
Okay. So, and again, 4 is another validation, just like 2.
Yeah. So do you want to start with?
Yeah, let's start. Yeah, sure. We can do that today. In order to be able to find out what kind of tests we need, is it okay with you if I ask some questions about your sexual life?
Yeah, go ahead.
Yeah. Do you have a partner that you have sex with? Do you ever have sex with somebody else?
Yeah.
Okay. And does that person have a penis? Does that person have?
Like I have sex with, people of different genders, like some men, some women, some people who are non-binary.
Yeah. So you kind of, and I thought you were gonna do the.
Well, so
but
sorry.
No,
keep going. Keep going.
I'm gonna keep going. Okay. Great. And do you, when you have sex with your various partners, how do you cover or protect any of the body parts that are involved? So when you have sex.
Wait, can I just stop you right there?
Yeah.
I mean, do I actually have to answer these questions? Can't I just get the tests and go?
Absolutely. Do you have a sense of what testing you would need?
Well, you mentioned like rectal and
so would you like me to sort of flesh that out a little bit for you?
Yeah, like can you go over can you go over the options for me?
If you've had any penis in mouth sex, we should swab your throat. If you've had any penis in rectum sex without a condom, we should swab your rectum. If you've had any penis in vagina sex, we should swab your cervix or get a urine sample. That's it.
Yeah, can I just get the rectal swab and the urine test and can we like?
You seem kind of uncomfortable. Is this okay to be able to?
Yeah, I just don't want to. I just hate these questions and I just want the test and I don't really want to answer any questions.
Totally get it. It can be really uncomfortable. Yeah, and you know what you need. So
yeah,
okay, a rectal swab, HIV. So we'll draw a blood test for you today for HIV and syphilis, and
great.
We'll get a rectal swab.
That sounds great.
Sounds perfect.
Oh, and
for chlamydia and gonorrhea.
And a urine test, please.
Absolutely.
Okay, thanks. Kelly?
And plus, I thought we were doing a slightly different thing with the role play, so that's why I had.
Well, so I let you go on a little bit more and then I was going to cut you off. I was going to cut her off right away, but I let her go a little bit further. Kelly?
Yeah, I don't know. There were some pauses in there.
There were pauses.
I don't know.
Okay.
I think it wasn't maybe like 4-ish minutes.
Okay, that's fine. And you know what? And you could make it even shorter, but I was letting Patty go on with the sexual history taking, and then I was like, wait a minute.
But I didn't think I was going to be asking.
I know, sorry. Well, so
it's like, well, okay, body parts.
So, I think the trick question that we said was, Patty actually never got any sexual history from me. I just said, order these. Can I just get a rectal test and these tests? So it's very helpful to know what goes in where. But we don't actually need to know the number of partners. And you could actually just offer them like you did. You're like, well, we can get a rectal test. We can get a throat test. We can get this. And say that's on the menu. You just pick and then they leave. And so it's not satisfying as a clinician because you're like, oh, I know how to take a sexual history. I want to do a good job. But
I don't agree. I actually think it is satisfying. I find it really satisfying to acknowledge that a patient's an expert on something for themselves.
Yeah.
And this patient, I'm going to say this patient, the way we had framed it, knows about all these things. They know exactly what they need, and they don't need me to actually have a conversation with them about it. And that makes me happy to be able to find somebody that knows what they need to know and that they have their own, power.
Yeah. And sometimes though, as a clinician, I think like, oh, I wish I could make them feel more comfortable talking about this. But I think, to be fair, in that interaction, I'm about to leave, or I'm sorry, you're about to leave and I'm about to leave, and I just want to get this done. So I think that was great.
And these share options, you saw that what I did was, as an alternative to asking a sexual history, I told her the information she would need in order to make the choice about where to be tested.
We're going to skip the poll because we're going to actually go to the end. Yeah, these are the asks that she offered me. You know what I mean? Like, here's the test that we can do. What do you want? And
actually, can I say, I blew it, because when you were saying that you had all those partners when I didn't, because I didn't think we were doing a sexual history, and yet I could have come back and said, considering that, do we need to test your penis, cervix, throat, or anus today?
You could say any of those things. But I just want to point out, these are our final thoughts. Would you like me to do them, or would you like to do them?
We can alternate.
We can alternate. So keep your affirmations very brief. They could be one word: wow, or
amazing,
amazing, I'm sorry, awesome, great.
Keep each share limited to one simple concept, and then follow it with a question, listen to the answer, acknowledge them briefly, and then more content, more content, and more content, and more content. But just keep each share limited.
Give your recommendation. We said that twice already. I want to leave a few minutes for questions. So it's okay for you to say, we don't do that, or I don't do that.
Yet it's very important, if you are willing to do it, to put that up front to save you time with the conflict, to reduce conflict.
Yes, go ahead.
And then we wanted to leave you with, ultimately, the patient is the one who's going to make the decision about what they do with their body, what medicine they take, who they have sex with, where they have sex. And we think we have some kind of control over that, but really and truly we don't. So if we really take that to heart, then we won't assume that we should be able to tell somebody this is what you should do and expect them to do it.
Right. Questions from the audience, and I'm going to just put up that we are coming toolkit. Yep. And here's the way to get a hold of us. If you want more slides around PATH, please email Patty, patty@medalla.com. And if you want more slides around STI content, email me. And Kelly, do you have questions for us? Oh, you're on mute.
Classic Zoom mistake. Hey everyone, I'm Kelly. I do have a head, not just a voice. So that's the good news. Thank you both for giving this talk. That was a lot of role playing, and it was live and it was not scripted. So kudos to you. You did get some shout outs in the chat.
We're
questions.
brave.
You were brave, yes. Folks were, I would say, most interested in the sexual choking topic, probably because it's less familiar to many of us, myself included, I'd say. So people were asking about the study that you showed among college students. Do you know if that was specifically heterosexual study folks, or was it all comers in terms of sexual activities? So I'll ask that one first.
Yeah, it included people of all different gender identities and sexual and gender identity, sexual orientation and gender identity.
Great. Along similar lines, someone was asking if there's a study or another publication that we can share with students regarding choking and health consequences. I would say you already shared the one on that particular slide with the 973 college students. Do you think that would be
the one on there's data on mental health stuff that we didn't put up, so we should probably get that to you.
Yeah, there are studies looking at choking and its relationship to negative mental health outcomes, particularly anxiety and depression.
And are you saying college students, right?
That those studies were also in college students. And I think the question is there a handout, like a handout for patients? Is that what you're asking, Kelly?
They asked about study or publication, but I'd be curious too if there is any,
so
pager for students or something.
Yeah, with these course materials, with these course materials, I can add those. There's multiple studies actually looking at but it's not, we don't know if it's cause and effect. Like, are people who are anxious and depressed more likely to choke, or is choking directly involved in anxiety and depression? So it's an association, not necessarily causation.
But those
Yeah.
biomarkers for brain
Yeah.
inflammation,
Yeah.
that's hard science.
Yeah. That's hard science.
And helpful. Thank you. Okay, the last open question in the Q&A is a different topic about STI screening.
Yeah.
How do you know how common it is to utilize nurses or RNs to do STI screening for student health clinics?
Yeah, I mean, that's a state dependent um, issue, because certain states will allow RNs to do what's called expanded scope of practice, which means that they can actually do STI testing without a like physician or other, you know what I mean, licensed provider. So under a protocol. So, but that's a state by state thing. In the state of California, my understanding is it's not allowable, but in the state of Nevada, it is. So that's really an issue that I can't like answer depending on where the person is located. But people can certainly, yeah. So I mean, again, it's like one of those. It depends, but it certainly can be done and can be done successfully. It's been done in other states for sure.
Wonderful. We have answered all the questions in the Q&A and we are right at time. So I want to thank you both again for your bravery, for doing all those case scenarios and for talking about this.